It's Eric again, and today I'll be talking about those diseases directly caused by fungal infections. The specific learning objectives are to describe the general features of fungal infections, to list risk factors for developing a fungal infection, and to describe the clinical manifestations of common fungal infections. I would like to point out at the very beginning that this video will not go into significant detail about the unique manifestations or specific diagnostic testing of all the individual fungal diseases. That will take hours and hours to do. As the title states, this video is giving just a quick overview. So what are the general features of fungal infections? First, they are seen most often in immunocompromised patients, exceptions being infections from dimorphic fungi and dermatophytes. The presentation is typically subacute to chronic. Exceptions here are candidemia, which is a candidal infection of the bloodstream, and mucormycosis, which I'll talk about more in a few minutes. Person-to-person transmission does not occur aside from occasional dermatophyte transmission, as well as that from mucocutaneous infections of Candida. There are no specific symptoms or signs which reliably distinguish fungal from bacterial infections. And last, typical antibiotics are ineffective, with the notable exception of pneumocystis. Next, what are the risk factors for fungal infections? I mentioned immunosuppression a moment ago, but can we be more specific? This chart is going to be very generalized, as there are some very specific risk factors for very specific diseases. However, for the most part, risks can be divided into major and minor. The major risk factors for fungal infections include hematopoietic stem cell transplant, such as a bone marrow transplant, particularly in the first 30 days, induction chemotherapy for hematologic malignancies, such as acute leukemia, and solid organ transplantation. Minor risk factors include any other chemotherapy, critical illness of any kind, mechanical ventilation is an independent risk factor, indwelling lines, hemodialysis, TPN or total parenteral nutrition, malnutrition, AIDS, mucositis, recent use of broad-spectrum antibiotics, diabetes, and recent intra-abdominal surgery. Now, of what fungal infections do these factors place a patient at risk? In the last video, I discussed a practical classification of fungal species in which they were placed into one of 5 categories. Here's an analogous classification of fungal infections, which will also coincidentally use 5 categories. Those categories are superficial infections, mucocutaneous infections, subcutaneous infections, and deep infections, which are further subdivided into primary deep infections, meaning those which healthy people can acquire, and opportunistic deep infections, which are almost solely seen in those patients with one or more of the aforementioned risk factors. I'm going to go through each of these categories one at a time, and I'll be using my friend David here to highlight the locations. I'll start with the superficial infections, which generally don't adhere to the aforementioned risk factors, and almost all of which are caused by dermatophytes. From the last video, those are the pesky, non-dangerous, but difficult to eradicate fungal species which can live off of the keratin in our skin. Since we almost never care about individual specific dermatophyte species, most superficial fungal infections are simply named after the location on the body where they're found. So on the head, we have something called tinea capitis. On the jaw in men, there is tinea barbier. On most of the torso, as well as the arms and legs, is tinea corporis, more commonly known as ringworm, given its circular and sometimes ring-like appearance. If not already obvious to you, a ringworm infection has absolutely nothing to do with actual worms. In the groin, there is tinea cruris, more commonly known as jock itch. And in the feet, it is tinea pedis, more commonly known as athlete's foot. There are just a couple more remaining superficial infections. Candida intertrigo is a skin infection by Candida yeast, which can occur within skin folds that are highly moist and infrequently cleaned. This most commonly occurs in the groin and between the buttocks, but also can be seen under female breasts and occasionally in skin folds of the abdomen and neck in patients who are morbidly obese. Onychomycosis refers to a fungal infection of a nail, which is an extremely common problem, with overall prevalence in the adult population measured anywhere between 4 and 18% of all people. That's huge. Onychomycosis almost always involves a toenail, but it can be a fingernail as well. The infection is usually due to dermatophytes, but can also be from Candida, and even rarely a mold. And last is a distinctive infection called tinea versicolor. Despite the word tinea in its name, it's not actually caused by a dermatophyte, but rather yeast of the genus Malassezia. Tinea versicolor most commonly presents with well-demarcated macules of either hypopigmentation or hyperpigmentation located on the torso and upper arms. When numerous, they can coalesce into large patches. As with onychomycosis, this is an extremely common infection, but has a higher incidence in tropical countries as compared to temperate ones. The next category of infections are the mucocutaneous ones. There are 3, all of which are caused by Candida. A candidal infection in the oral cavity is called oral thrush, which manifests as white pseudomembranes on the tongue, buccomucosa, and palate. These pseudomembranes can be easily scraped off, and if the diagnosis is uncertain, that material can be examined under a microscope, though this is rarely necessary. A candidal infection in the esophagus is called simply esophageal candidiasis, or occasionally candidal esophagitis. Diagnosis requires upper endoscopy, but should be clinically suspected in any immunocompromised patient who develops painful swallowing, particularly if the patient has concurrent oral thrush. The last of the mucocutaneous infections is vulvovaginitis, more commonly referred to as a yeast infection, which is extremely common and generally not related to immunosuppression. Subcutaneous infections are fairly uncommon, at least here in the US, so I'll just mention one, sporotrichosis, caused by Sporothrix shankii. Sporotrichosis is most commonly caught after soil or other organic material containing the fungus is inoculated into the skin through minor trauma, giving it the nickname rose gardener's disease. Clinical infection will become apparent days to weeks after initial inoculation, with the development of an ulcerated papule at the initial inoculation site. Similar lesions then crop up along the downstream lymphatic drainage. This man here in this picture has a particularly severe infection. Most infections are more mild in appearance. Next are the deep primary infections, and we are now moving into the infections which are academically more interesting. The deep primary infections are those caused by dimorphic fungi other than Sporothrix. CNS infection due to dimorphic fungi is the first I'll mention, though this is essentially to get it out of the way since it's quite rare. CNS involvement from histoplasmosis and blastomycosis usually occur in the setting of otherwise evident disseminated infection, while meningitis secondary to coccidioidomycosis can occur in the absence of pulmonary symptoms. This form of cocci infection is particularly challenging to diagnose as its presentation is very gradual, occurring over weeks to months, and the most common symptom is a very nonspecific headache. The bulk of deep primary fungal infections are pulmonary infections, and these can be from histoplasmosis, also known as cave disease when it occurs in the lungs, blastomycosis, and primary coccidioidomycosis, also known as valley fever. These 3 conditions share some of the same mechanisms and manifestations, and can clinically be indistinguishable from one another using just a history exam and routine studies, so I'll talk about them as a whole for a few minutes. The pulmonary disease caused by these 3 fungi is primarily the result of inhaling spores that were residing in the soil. Many of the infections from histoblasto and cocci are actually subclinical, meaning that the patients are either asymptomatic or so minimally symptomatic that they don't seek medical attention. Among immunocompetent people, it's not known why some develop asymptomatic infections, while a small minority develop severe life-threatening infections. It's partly related to the size of the inoculum. In other words, a greater number of inhaled spores at the time of initial exposure will increase the likelihood of severe disease, but this does not account for the difference completely. Presentation of pulmonary infections from the dimorphic fungi are usually subacute or occasionally chronic, meaning that there can be a delay of several weeks between exposure and presentation, which makes the diagnosis more difficult. The common symptoms of these pulmonary infections are fever, cough, substernal chest pain, which can be pleuritic, and so-called constitutional symptoms, referring to modest weight loss, fatigue, and just feeling lousy overall. Interestingly, while these diseases can certainly cause shortness of breath, it is only a minority of patients who report this symptom at initial presentation. Unfortunately, the physical exam is typically unremarkable in these patients, aside from a fever and some nonspecific lung findings such as patchy crackles. The chest X-ray of symptomatic patients is usually abnormal and may be the first thing to suggest infection from a dimorphic fungi. Common findings include patchy or nodular infiltrates, which may be either unilateral or bilateral, and hilar and or mediastinal lymphadenopathy. The one exception is that blastomycosis isn't usually associated with a lymphadenopathy. There are certainly many other potential X-ray findings, and none of these are pathognomonic for one particular infection. As mentioned before, these three infections are clinically quite similar to one another, but they are also similar to tuberculosis, sarcoidosis, and lung malignancy. I'll also mention here that all three of these infections can cause extrapulmonary disease, for example, the aforementioned cocci meningitis. For cocci and blasto, the most common sites of extrapulmonary disease are the skin and soft tissue. Histoplasmosis, on the other hand, can cause a severe disseminated infection, particularly in patients with immunosuppression from AIDS or organ transplantation. Since all three infections are quite similar, making a specific diagnosis seems like it should be tricky, but luckily geography can be quite helpful, as the overwhelming majority of histo, blasto, and cocci occurs almost solely in specific regions. Starting with histoplasmosis, it is found in the American Midwest, South, and in the southern Appalachian Mountains. The territory of blastomycosis is partly overlapping, but stretches as far east as the Atlantic and as far north as southern Ontario and Quebec. The territories of both are frequently described in textbooks as the Ohio River Valley, but as you can see from the map, the territories are actually much larger than this. And finally, coccidioidomycosis is found predominantly in the American Southwest, Southern California, and northern Mexico. The highest concentration of cases are found along the Rio Grande, in southern Arizona, and in the San Joaquin Valley of California. For those of you not native to California, the San Joaquin Valley is more or less synonymous with the southern half of the state's more commonly known Central Valley. I haven't found a source that states this explicitly, but I assume that the common name of valley fever is named after this San Joaquin Valley. Cases of these three dimorphic fungi can occur outside of these geographic regions, but this is extremely rare. So last, we have the most dangerous category of fungal infections, the deep opportunistic ones. These are the infections which rarely occur in healthy individuals and unfortunately typically have high mortality rates. Opportunistic fungal meningitis can be due to either cryptococcus or Candida. And ophthalmitis, which is infection of either the vitreous or aqueous humor of the eye, is usually caused by Candida and occurs in the setting of candidemia. Due to the possible consequences of significant visual impairment in the event of a delayed diagnosis, all patients with confirmed or suspected candidemia should undergo a dilated retinal examination, preferably by an ophthalmologist. Mold can also cause ocular infections, but this is less common and is typically a consequence of eye surgery or penetrating eye trauma rather than hematogenous spread. One of, if not the most feared of all fungal infections, is rhinocerebral mucormycosis. This infection is acquired by inhalation of spores, after which the mold literally takes hold in the nasal turbinates and sinuses, causing a clinical disease indistinguishable from routine acute sinusitis, at least indistinguishable at the very beginning. Unfortunately, the infection rapidly spreads via direct extension into the palate, orbit, and the brain. Diabetes is a primary risk factor for this disease, particularly in diabetic ketoacidosis. Treatment requires a combination of prompt antifungals and surgical debridement, which can be extensive and significantly disfiguring. Given the speed with which it spreads, mucormycosis needs to be considered any time a patient with significant immunocompromise or active diabetic ketoacidosis develops symptoms and signs of acute sinusitis. Despite vigilance for the diagnosis, mortality still ranges from 25 to 60%. The lungs are a very common place for deep opportunistic infections, which can be caused by mold, yeast, or pneumocystis. Aspergillus in particular has multiple patterns of lung infection. One pattern, called invasive pulmonary aspergillosis, presents clinically as pneumonia in the setting of neutropenia or high-dose steroids, often associated with hemoptysis. One of the more specific radiographic findings of fungal disease in the lung is something called an aspergilloma, or more commonly a so-called fungus ball. This is literally a giant mass of fungus mixed with fibrin and mucus that is thought to develop within a pre-existing lung cavity. Although it sounds quite unpleasant, surprisingly these patients can be minimally symptomatic. There are also, of course, fungal infections of the blood, as well as endocarditis and central line infections, which is usually due to Candidal species when secondary to a fungus, though this can also happen from some molds. Finally, Candida can cause urinary tract infections. However, a definitive diagnosis of this is often impossible, since many patients, particularly those chronically ill or with an indwelling Foley catheter, can have urinary tracts that are colonized with Candida all the time. I'll now move on to discuss how to diagnose fungal infections. This will be just a quick overview of the more commonly used diagnostic tests. Some practice settings may have more specialized testing available. Aside from clinical diagnosis, microscopy on fluid or tissue samples provides the most rapid means of diagnosis. As mentioned briefly in the first video in this series, molds in particular can be identified from their specific morphologies under the microscope. There are 3 helpful preparations and stains of which you should be aware. Potassium hydroxide preferentially dissolves keratin and human cellular material, leaving fungal cells relatively intact, making them easier to identify. Something called chalcofluor white is a fluorescent stain that binds to chitin and provides pretty pictures like this one when exposed to fluorescent light. Finally, India ink, the very same substance used for writing in Asia for the past 2,000 years, can be helpful in diagnosing cryptococcal meningitis when applied to CSF. Since the ink dyes just about everything in sight black, but is unable to enter the capsule surrounding the encapsulated yeast, it can create the appearance of haloed cells. Now, what about cultures? Candidemia specifically can be detected by routine blood cultures, and no special handling or processing is needed, but sensitivity of cultures is unfortunately estimated to be around 50%. Specific fungal cultures can be ordered on blood, but this is only helpful in suspected systemic infections by molds, for which a positive culture may take up to a month. Fungal cultures can be also performed on any other fluid sample, but as with blood, may take weeks for a positive result. As different labs may have different protocols for culturing fungus from specimens, consulting your local lab prior to obtaining samples is probably best. In addition to microscopy and cultures, there are a few other types of tests out there. Antigen and antibody tests for various fungal infections exist, for which the cryptococcal antigen and anti-cocci antibody tests play the clearest role. And last, there is a test for something called galactomannan. Galactomannan is a polysaccharide that is a component of Aspergillus cell walls. It is used in an enzyme immunoassay for the detection of this infection. It has a fair sensitivity and high specificity, though testing in a population with low disease prevalence results in a low positive predictive value. There are a few things which can cause a false positive of the galactomannan test, among which concurrent treatment with the antibiotic piperacillin tazobactam is probably the most frequently cited. I'm going to end here. The next video in this series will discuss those medical problems which are indirectly caused by fungi, as well as a little bit about how pseudoscience in the modern world looks at fungal infections.